So welcome everybody to the grand rounds. Good afternoon. Hope everyone's keeping well and had their flu vaccination. Just to update you that at the moment you can get the previous grand rounds via the GLA YouTube channel, which is externally facing. There's videos on there, or via the Gold internal website. They're well worth a watch if you haven't caught up with the previous grand rounds. I mean, you can get CPD certificates for this, the grand rounds, if you need them for your appraisal purposes, and then you can get those via the SurveyMonkey feedback tool, which will come at the end of the grand rounds. There's a link will come up at the end of the grand round that, or you can email us in PGME and we can send you a link to the SurveyMonkey tool, and then you can get a certificate of attendance for this grand rounds, and you can self-score 1 CPD points for attending. Right, okay, so this session today, we're going to go through about 35 to 40 minutes of 2 presentations, which I'm really looking forward to, and then about 5 to 10 minutes of questions at the end. So it should be done by 2 o'clock. It's my great pleasure that actually one of the most important subjects, you know, from the anaesthetist point of view, is IV access. A lot of the treatment we give our children does depend on IV access and treatment and nutrition. And it's always a huge issue, we know, on call and planning going forward for the treatment. So we're going to hear from the peripheral and the central venous access team. And that is, and they work together synergistically. And we're going to start, as you would do sort of normally in clinical area, with the peripheral venous access team to give us an update on their roles, escalation policies, and some of the technical things they use to help us out. So over to Kerri-Ann and the peripheral venous access team. Thank you.
Hi, so I'm Shelley from the vascular access team. I'm just going to introduce us and what we do. So we are a team of highly competent and experienced vascular access facilitators. There are 5 of us in our team, which a couple of years ago were only 2. So we have increased the numbers. We work pan-trust to deliver venipuncture and cannulation for extremely difficult patients and who have had multiple unsuccessful attempts, whether that be in here or in a local hospital. So we normally attend patients that are either grade 3 or above, or as I say, they've had multiple attempts previously. Just a big thing here, we're not phlebotomists. I think a lot of people think that they can call us up and we'll just come and do their bloods and cannulas for them. Our role is actually, as I say, to go to the difficult patients, which we get a lot of here at Great Ormond Street Hospital. Those kind of patients sometimes we've seen before and they've come back on multiple admissions. And what we would say here is actually if they are a patient that has been here before and have been known to be difficult, planning the patient's admission, we have an email address where actually we are contacted by multiple teams for patients that have known to have difficulty in the past, have had bad experiences, and they will email us to kind of pre-book so that actually we can plan the patient's admission, we can plan what it is we're going to do and a strategy to kind of make that patient's experience a little bit better. By doing that, we use PLAY specialists. We have a good rapport with lots of PLAY specialists on the different wards, where we will get them involved in patients that have had traumatic experiences and are extremely needle phobic, or just as distraction for the young babies and kids of all ages. And they are a fantastic resource that we have here at Great Ormond Street. Obviously, the use of topical analgesia, we are huge advocates for use of Amitop, Emla, cold spray and sucrose, which sometimes are not used enough around the trust, and we kind of promote that in our doctor's induction and on our venipuncture cannulation course. So the protocols and policies are on the intranet if people are unsure of the ages that we use those from. But yes, the use of topical analgesics is really important in venipuncture and cannulation in paediatrics. In regards to the escalation process, so the policy here at Great Ormond Street is that the ward staff, whether it be the doctor or a nurse, HCA, will have 2 attempts on the ward. And then if unsuccessful, then they escalate upwards So obviously then it would come to us, and then if we go and we've had our 2 attempts, and if we are unsuccessful, then we have to refer back to the consultant looking after patients, and kind of looking at a new plan and action for maybe a change in the patient's treatment plan, or whether it be a discussion with the anaesthetists to see if they can come and use an ultrasound machine. Sometimes we find that actually people aren't planning the care appropriately, and actually these patients are known to be coming in for maybe a 6 weeks course of treatment, and actually it hasn't been requested that this child might need a PICC line. So actually what we find sometimes they're going through cannulas every day, and we kind of have to look at that and say, look, you know, where are we going to go going forward? This is an unrealistic plan, and a better plan needs to be put in place, and therefore we might get them to speak to our IR and the CVAT team to escalate appropriately. As you can see here is a vessel health prevention framework. So this is what we look at in regards to vein grading, which you can do on Epic, and each patient has a vein grade come up in their summary. So obviously you can see there the different things that come up with that. So excellent, obviously palpable, really visible vein, straight, with good blood flow when you're trying to refill the vessel. And then obviously going along there, you can read that we do obviously go to patients that are poor vein grade, and pretty much non-identifiable there. So we will go to vein grades of 5, and obviously that's when we're thinking that we need something better in place for these patients, and coming up with a better treatment plan if it can be changed. You can see here in this slide that there are different things that we can put through peripherally and centrally, and we have to kind of look at that. Sometimes it's not appropriate to have peripheral access if they're on things like TPN and stuff, and actually if they want to start that, we need to look at a slot in IR for a line. It does show us here obviously tips for success, so the different things that we use. So we use our WeSight. That is our very handy tool that we cannot live without. We use that for most of our patients. So you'll know when we've been in a room because the lights are off and the bed's probably really, really high with the sides up. So as I say, use of aids. So WeSights, normally most of the wards have them, but if you can't find one and there's a doctor that needs to have a look and can't see anything with their eyes, then actually the CSPs do have spare WeSights. That they don't mind being contacted, or even ourselves, that we can either come and bring a wee light to you if you want to have a look. We do have AccuVeins as well, which are good for the older children with a stand, as another form of identifying vessels. Good use of distraction, so play specialists or any kind of pads, television, anything the child might like that they think might distract them. Also thinking about the environment, it's good to use, if there's a treatment room, it's good to use the treatment room so that actually we can take the child away from their safe space, which is their bed, their wheelchair, you know, so that we can do it in a room that is just purely for that clinical, so they can be taken away from their safe space, have their procedure done, their venipuncture cannulation, and then go back to their bed space. We see it all too often when actually children are having it done in their beds, and you know, it's good to be taken away when we can. And the use of parents and cuddles. That's it for me. So we have a bit about data. I'm going to hand you over to my colleague Kerri-Ann, who will talk to you about some data that we've collected over the last couple of years. So obviously we've done the data from September 2018 to September 2019. Obviously with COVID, obviously, and the lower numbers of patients being admitted, it's not really an accurate, true reading of the amount of patients that we see. So between that year, we had a total referral of 2,871 patients. Obviously, you can see that there was more cannulation required than venipuncture. Obviously, during this time as well, our team did increase in size. So as Shelley had said earlier, we'd gone from 2 people to 5 people. So obviously, we looked at January specifically in 2019. So we escalated 8 patients to anaesthetics in that month. And when we looked at it, so 50%, so 4 of those patients had had multiple attempts before, and then they ended up being referred to the central access team requiring PICC line, femoral line, long line. So obviously we was unsuccessful on 15 patients in January, which, as I said, 14 of them had had multiple attempts before being referred to us, which we find happens a lot. When we look back, we think actually if they'd been assessed properly from the vessel health tool, obviously we do have the policy in the trust where people should try twice, but actually if the patient is a grade 4 or 5, they need to just get escalated to us, because obviously if somebody's trying 2 attempts, then actually that's just really restricting us, and we just have less chances of success. And then obviously it ends up the patient having multiple attempts here as well. We had quite a lot, so over the 12 months, we had a lot of referrals from chameleon ward, bear ward, pelican and squirrel endomet. We think obviously chameleon have quite a lot of babies and young children, and bear obviously their dependency is quite high and they're requiring their access quite a lot. We have noticed that actually an increase in referrals happens when the junior doctors occur, and I think that's just because obviously they're trying to get into their role here. Obviously some haven't worked in pediatrics, and you know, and obviously we're happy to support them with that. Obviously this is just to have a little look. So obviously you can see with the vein grades, so from that year you can see obviously most of our patients are grade 4, and obviously, as I said, with the busiest wards that we've had as well. So we do still have quite a high priority of urgent patients coming through, so we sort of say urgent patient is, you know, within an hour really. Obviously we do cover the whole trust, so we are quite busy. Sometimes obviously if we're not busy, we'll go to the patient straight away. Obviously it depends on the urgency, and obviously we referred patients from the CSPs and things as well. We do have some patients that are booked, as Shelley said, obviously ones that we're aware of that we've met before and obviously are coming in multiple times. And then obviously the non-urgent patients, the patients coming in to the wards for MRIs and things like that. Obviously, we know that they are, for the patient, obviously it is really important, but for us they are slightly lower priority, but obviously we will try and get to them as much as we can. So we looked at August as a month, particularly. So in August 2018, where there was only 2 of us in the team, there was only 55 patients referred to us, where last August in 2019, there was 286. And then even with COVID-19, we had 258 patients referred this August. So obviously that is still quite a lot. Obviously with the 2,871 patients that was referred to us in that year, we were unsuccessful in 276. That does actually include patients that come back reoccurring. So if we see a patient like 1 week and then they're re-referred to us the following week, sometimes obviously their veins haven't healed, then obviously we're going back to them, and then obviously we are unsuccessful. Obviously we try not to escalate them to anaesthetics. Obviously we know that they're a very busy team as well. And obviously, as Shelley said, that's why we try and advocate for the patient and say, actually, can they get changed to orals, or do they need a central line and things like that. As you can see, so we were successful in 85% of our total referrals, which I think is actually quite a good number. And then obviously the other 15% obviously were patients no longer required. So patients that either somebody on the ward had actually attempted because they thought they could, and obviously patients that CAT scans got cancelled for what other reasons and things. As a team, I just thought this was quite a good fact. We took 8,939 mils of blood in that one period from September to September, which seems a lot, but it doesn't as well, obviously. But bearing in mind, obviously, a lot of our patients are very small, and you can only take 1.7 mils of blood per kilo in a 24-hour period. So obviously we go back to patients, as we said, so patients that are here obviously admitted for a long time, and obviously we found that sometimes they need resit, like cannulas reinserting, and we sort of looked at this to see why this was. Is it because the patients are difficult because they've got small thready veins, or because they're little? Is it where they've had multiple previous attempts either here or at the local hospital? And then are the cannulas being looked after properly? So we will always splinter patients, cannula, and bandage it up. Obviously, we do go back towards, and actually you see that the cannula is basically hanging out of the hand. So we would always obviously try and secure it down as much as possible and just try and advocate for that for the patients as well. As I said, obviously patients undergoing multiple attempts at previous hospitals, we get some that come in and the A&E have tried 27 times, for example, one of our patients recently. Obviously we understand in an emergency situation, obviously what needs to be done, but obviously here we would never do that. And if obviously it got to that point, then we would obviously escalate. And if the patient was quite unwell, obviously then they would require an IO through anaesthetics and icon and things. Obviously, is there a lack of skill with and knowledge with staff? So obviously sometimes, especially with the little vessels, we can only put a neophlon in, and are people trying to bleed those back for blood samples, which obviously then you have risk of rupturing the vein. Where sometimes it's easier just to come and do a venous sample separately. I know obviously that sometimes means another needle, but a venipuncture is nicer than a cannulation. Obviously doctors, so we've obviously we have doctors come and work with us as well, so I think sometimes we do need to advocate for the doctors and for staff, so nurses and HCAs and stuff, to have some protective time for teaching, either learning the skill or just having a bit of a refresh, because everybody needs obviously refresh, things are constantly changing. And then obviously, is it due to the poor assessment of vein grade? I think some people can go and look at a patient and say, you know, they look like a 3 or 4, but actually they're not, or, you know, vice versa. So some people will say, oh no, I think I can get it, and actually this child doesn't have many other vessels or many other options. So yeah, obviously if patients were assessed properly using the vessel health tool, would they have had less referrals? And then it's just of how to contact us. So as Shelley said, you can always pre-book us with a patient. So if somebody, you know, has had multiple attempts, or if somebody, you know, with extra needs us as well, obviously play specialists are the first port of call for those sort of patients, but we're always happy to come and help and support as well. Obviously we're here, we do long days, we cover Monday to Friday, and the bleep is obviously 0082, so we're more than happy for any referrals. So what I'll do is I'll hand you over to Anne, who is in the Central Venous Access team.
All right, thanks, Shelley. So I'm Anne Ho. I'm the Central Venous Access team lead. So CNS by trade, and I'm a nurse. I have 2 team members, band 6 on my team. So I'm just going to run through what we do from a CVAT, which is a Central Venous Access team role. Okay, so I look at this as a 3-part role. Okay, so the first ones that I think most of the wards in the hospital, from a medical point of view, will know that we actually accept all CVAD referrals to interventional radiology. So that can be by Epic. We quite often, the teams are very good at giving us telephone referrals, you know, just making sure that we have slots available, but referrals come through us, and every single CVAD comes through CVAT. Okay, they don't need to go to our IR consultants. We take responsibility for those as well. And obviously the places will be combinations of interventional radiologists, our clinical specialist radiographers, and also myself from a learning point of view as well. That's our 3 points we do. I also, from a team lead, have responsibility for any child that has a central venous access device in this trust, but also across shared care hospitals. We get random calls from other hospitals. So if a child has a line, kind of comes under us, and we will help where we can. Okay. So as I mentioned before, the IR list is the 3rd one. So the next slide, we're going to go on to, slide gives everyone an overview of how many devices we get requested in IR. This is from 2019. Didn't pick this year because COVID kind of changes the gameplay of what we actually placed in a similar vein. So we're pretty popular, okay, you can tell. 1,400 over a year, and we only provide a weekday service, ideally. So our most common users are HEMOC, and we seem to be quite popular with cardiac. Essentially, these tend to be the areas that need more central venous access devices, and they need it more for a long-term basis. Okay. If I refer you to the little pie chart on the bottom right, okay, it gives you an overview of the urgency of the requests, and these are after they've been protocoled by like me on my team. So 53% of referrals that come through to IR are what the teams refer to as urgent, and quite commonly they would like the same day process. The 18% is for the routine, so that would for us be about within a 6-week time period, ideally. The 13% is your soon, so we would look at that about within a 2-week period, and 7% specific date. So there might be tagged with another procedure that teams want, or in terms of like stem cell harvest, those are quite specific dates that we need. Okay. So the next slide takes us to our protocoling. Okay. Being perfectly honest, this is pre-EPIC, but it gives you an idea of what we would ask you to do, what I expect my team to actually look at before that child will go onto the table in IR. Okay, so we are very demanding. Okay, but I want to know that when a child goes on the operating table, then I've done everything I can to make sure they're safe. Okay, so that we'll look at their clotting status, because obviously bleeding is a concern, and we look at their infectious status, so we don't add on any infection to the next child on the list. And consent is quite a common feature that we need teams to help us with. So that just give you an overview of why we are quite specific and quite demanding. So I'm going to run through types of devices. Okay, just very briefly, just give you a very quick picture of the type of devices that we place in IR. There are a few other extra ones, but for most of you, you'll know that there'll be the Hickmans, the ports, the PICs that are our most common frequent flyers, and the little dialysis catheters. Okay, so indications for devices. Okay. If I looked at all the 1,400 we did last year, there are loads of reasons. So I've just grouped them into most common themes. Okay. As Shelley and Kerri-Ann mentioned, difficult access is quite a common theme. We work at GOSH, we have pediatric patients, and by the time they get to us, they've had obviously blood tests, most commonly at the local hospital. So their vein grades are generally on the upper scale, so at 3, 4, 5. And Shelley has also mentioned the VHP framework. That's a good reference guide for teams to look at. Okay. So we place lines for a variety of reasons. Antibiotics are most common. Okay. We do chemo, BMT, all the things that you can see on that list. Okay. We scroll down to the less common ones, which is blood sampling. So a lot of the endocrine tests need like blood to be taken within like every 30 minutes, every 15 minutes, and no child, and even I as an adult, do not like being stabbed that frequently in that period, and they need reliable access. So we'll do like samples for that. We will commonly also put in for the small babies lines, central venous devices for investigations. So I'm talking about kids that need that antenna levels, things like that. Okay. We do refuse some requests. So we've had a few where they want devices just in case. That's for us not a good reason for us to put a device in. There are multiple risks involved, and just in case is not good. We have had requests for people that want a one-off CT because vascular access has been challenging. So while we didn't put a central venous access device in, we actually offered them solutions to help to get the CT, which was managed in the end. The things that we consider, okay, and then we ask the referring teams to consider is what they need. Okay, we get requests for singles up to quadruple lumen devices. Never yet seen a quadruple lumen, but you never know as such. In my case, less is more. Okay, if a child requires a single lumen, we are unable to sign off on a double unless there's a really good justification. Okay. We look at the child's vessel size, the front size of the device, because the more lumens that the requester wants, the bigger the catheter. Okay, and obviously that makes it a little bit more challenging in terms of thrombosis, vessel occlusions, and that's the last thing you really want. Okay. We talk about cuff devices for babies because unfortunately we lose a lot of devices where it's being pulled, caught, anything. As children, the toddlers are good at pulling or biting. As parents, we've recently had a parent cut a line by accident, and as nurses, as doctors, as teams, we are also guilty of catching a line and pulling it, or other things that can happen. Okay. When we vet these patients, we look at, the level of treatment. So that will help us define what type of device to advise you as a team, what would be the best device for your patient. And we'll also look at the type of treatment. Things like vesicant medications will come into play about what device we advocate. Small babies, we will realistically change the type of device we recommend in comparison to like a teenager because of the safety issues of lines being pulled or vessels going. And I put on the bottom that actually I've got a crystal ball. So from a crystal ball point of view, I'd love to know what the kids need. Sorry, there's someone coming in. So on a crystal ball, I'd love to be able to predict what the child needs in the future, but none of us can. So it's an estimate at our point. Okay. So the second part, probably the biggest part of our job as well, to go with the referrals, is maintaining these devices. Once the device is in the patient, okay, it brings its own interesting challenges. Okay. So you can see the most common one, which is happening this week, is skin damage, which is MARSI, and it's been MARSI week recently. I think you might have all heard about. So the top right picture has a picture of a child with really bad skin excoriation. Okay, that is common when you have a dressing on the child all the time. It's common with some of the chloroprep cleaning solutions that we need to use, which are worldwide guidelines. So it's about how we manage it. Okay, occlusions are very common with us as well across the wards. Things, and then dislodgement, as you can see from the bottom right hand x-ray, that shows you that that line has actually migrated backwards or potentially been pulled backwards as well. So the next slide takes us to referrals also in 2019. So weirdly, the number of referrals we get for devices match our request for information or advice or actual support on the wards. Okay, so it gives you a rough view of the wards that we get referrals from. Same again, hemonc seem to really love us, and we're quite popular with the ICUs as well, and cardiac. So if you call us, okay, and there's a your child has a central venous access device, then we will come and help. Okay, it might be telephone advice, it might be we'll come and see the patient, but whatever it is, my end game is that when I leave you, that child either has a plan, or in an ideal world, that central venous access device is working perfectly, or we have a way to fix it. Okay, because if I can avoid a child going back on a table for a new line, that is my first and foremost, my most important job. It just gives you, same again as before, an overview in 2019 of the type of problems we had. Okay, so occlusions are a very big part of problems that we have. Okay, we talked about catheter size. We talked about, if a child has a 3 French catheter, okay, that's a 1 millimeter internal diameter. So from a nursing medical point of view, trying to get blood from the line means that occlusions are higher risk. Okay. It will also lead us into one of my future wishes, is that actually we need to have more time and more ability to actually offer training and education for the wards, so in the aim that we can actually hopefully reduce all the occlusion problems. Okay, broken and CVC or CVC repairs is quite common as well. And from that point, education, whether it's education of the family, education of teams, will reduce that. So the aim will be that we will have a slightly more chilled out job. That will be that point. So the next slide will take us to what I want for future. Okay, so coming soon, okay, on the wards and food anaesthetic, one of the anaesthetists, Nick, is looking at our midlines along with Helen. So there may be some children that you'll come across that would have midlines, and the idea being that very commonly when the children have a DA, they have a procedure, they tend to need vascular access of some sort, and a cannula, while being brilliant in certain situations, is not always what you need or enough. So a lot of the surgical children need PN afterwards for the bowels resting and things. So midlines may be a interim procedure until we can get to them. Okay. We're also going to be bringing out some ECG guided PICC insertions, which means that they won't need the imaging required. So that means that we'll cut down on their sort of like radiation exposure and ways we can manage that. Those will be the big kids. And as I've said before, I want more time to support education and be there for the teams, essentially. Okay. On the other side, I've got things that I want for the future, or as I put it, as wish list. Okay. I really want to cut down the age limit or the age recommendations for non-DA PICCs. Okay. But that will take a lot of child preparation, and we would need a lot of play involvement, because I find that works beautifully. Okay. I would really love to cut down on the access time for the patients. So when you come to me with a child that needs a central venous access device, then I can give you a slot within a shorter time frame. Okay. But obviously that takes more resources. And my ultimate wish would be for a CVAT, CSR, so that's the clinical specialist radiographer, a lab. So I call it IR4, which currently doesn't exist, but you never know. So I've gone down to my dream big at the bottom. Okay. So my final point will be the final slide. Okay, perfect. So I want every patient, and obviously to be part of the decision process. Okay, I am talking about parents and the families. Now we're going to have a chat with baby about what they need. Okay, my most important is that the child receives the most appropriate device according to their treatment. Okay, and obviously no harm. And our aim is that myself and my team will support that for all the central venous access devices. Okay, no child should actually experience trauma, and that includes the peripheral team, from lack of access or lack of experience with providing vascular access, be it peripheral, be it central. Okay, and by protecting those devices, those central venous access devices, okay, I want those children to be be able to have all the treatment they need as per required. Okay. So the hope will be that as one group, one team across the whole trust, okay, we will provide the best vascular access for the child. Okay. Whether it's a cannula, whether it's a Hickman, it doesn't matter. It's what that patient needs, what that child needs. Okay. Thank you.
Thank you very much, Anne and Kerri-Ann and Shelley, for those very interesting and really important presentations. I think that it's, as an anaesthetist, it's really close to our hearts that these children have that LV access managed properly right from the beginning when they come in, because you see so much distress when you're trying to get them in. We've had a few questions come in through from the people watching, which is great, and I'll go through a few of those now. Can you all hear me okay? You're not, good, okay. So, I think you talked about the vessel health tool, which is something that we've only really been using for the last few years. Now, who's responsible for actually using the vessel health tool, assessing the children, and then where do they put the results? And does every child that comes in have to have one? There's about 3 questions there in a row. Should we put that to the Peripheral IV access team? There we go.
So it's down to every single person that's looking after these patients to look at the vessel health tool. On the patient's document on Epic, it asks you to vein grade the patient. Obviously, if you're not competent in doing that, then obviously somebody that is competent needs to do that. And sorry, what was the last bit?
Yeah, so where is it situated? Is there a visual guide or a poster, or is it on Epic? Where is that situated?
So it is on the internet, but there are also posters around the wards as well. Obviously, probably not as visual as they obviously are at the moment, or should be at the moment, but they are definitely available everywhere. And on Epic, you'll see where it says the patient's details, the hospital number, it will say kind of CT briefs and stuff. At the bottom of that, at the very bottom, it says vein grade. And if it hasn't been done, it obviously say none. But any doctor that has tried, so when they're calling us and they're saying that this patient's a vein grade 4, they should be entering that on Epic that they think this vein grade's a 4. Every time that we see a patient, we will enter the vein grade and they will have a vein grade at the bottom, but it should be for every patient. And when anyone's doing bloods, inserting a cannula, it should be documented on Epic what their vessel grade is.
Okay, have you investigated with the Epic team whether you can make that a hard stop if they haven't filled out the vessel grade, and then you can't progress through the treatment pathway, as you would do for allergies or weight, for example?
Yeah, so it does come up now. It does say on their daily plan, but I think you can override it or not. Obviously, yeah, but maybe we should do it sorts with Epic actually with a hard stop. Yeah, because I think obviously it is very important. Because obviously if somebody hasn't assessed this child and then somebody just thinks it's okay and will go and have a look at them, then obviously this child's maybe having an unnecessary attempt before it being escalated appropriately.
Yeah, okay, that might be something going forward, it'd be great. And I've got a lot of questions about training of venous access and the junior doctors coming through, because our staff turnover is quite large, isn't it? Mm-hmm. So, first of all, do the junior doctors, are they trained with the special devices that you use? Are they able to get trained on the wee-light device or the cold lamp and these things that are really, really helpful, aren't they?
So they are, yes. So we have a training program that actually for any doctor that comes through the trust who has less than 6 months paediatric experience can come to us. So it gets sent out in their initial induction email with a link, one through the Gold e-learning, and also there's a link to book an appointment or a slot to come and work with us, to spend a couple of hours out of their day. And they will do that. So that obviously then we'll go through vessel health tool, the use of the wee light and other devices that we use. Obviously, we do try and encourage doctors to do it, and we have ones that are obviously very keen. So it's just trying to keep that momentum up, really, and that they do seek advice and kind of training from us. We can't obviously go out there and get everyone on board, but they should be, those people that have less than 6 months paed experience should be coming to spend some time with us. And actually, we've had really good feedback that it's been invaluable to the doctors that we have had that have come from adult settings or haven't had much paediatric experience, and like you say, haven't had much use of the tools. And we always say that if there's any doctor that wants to, feels that they can get the vessel, but they just want the support there with them, that we do offer, that they can call us, we can go and we can support them in having a successful attempt, whether that being using the WeSight and other devices. It's the same with nurses and HCAs and things. Obviously, we get people that come from external trusts, obviously, that have done it at their other trusts, and we're more than happy to help support them. And obviously, with as we said, with doctors' induction, and we do their venipuncture cannulation study day as well with the practice educators. Obviously, so we are obviously there as well to help support.
Okay, so they can. The question is, people do want to come and shadow you, I think, and that's fantastic. Yeah. So they just get hold of you directly by the Venous Access team, and they can arrange that with you personally, which would be brilliant. I mean, that's really helpful. Thank you. And is there much role? I mean, we're going to hear from simulation in 2 weeks' time, but is there much role in simulation? Do you have phantom arms and veins for people to practice? And if so, where are they available for people to come and practice on?
We've just taken a load of our shelf actually because it looked messy. But we do have practice arms, and obviously they are available from the Sim suite. We have some here. So obviously we do use those for the venipuncture and cannulation training days that we have. So they can practice them anytime. Obviously we're trying to use the tools in the WeSight and stuff. I mean, it wouldn't be very good for using that, but we're very good at kind of helping site select and showing them particular patients, site selections where we would look at the use of it and how good it is to use in different ways. But yeah, we do have the use of arms and stuff available. So actually, if someone we do have people that come from abroad that actually it's their nurses that do the venipuncture and cannulation. So actually they have nil experience and they do come here, and actually, we do have the arms and everything available for them to have a practice on, just to get the technique and use, get to know the tools and stuff that we use, the different butterflies and cannulas. So obviously it's different everywhere you go, and obviously making sure they're doing it to the trust standard.
Okay, that's really helpful. Thank you. So plenty of training available if people want it, which would be great on phantoms and with all the devices. And I think that 85%, we'd all agree, 85% success rate is extremely good. I'd be very happy if that was my first time success rate in the anaesthetic room, I must say. Maybe, anyway, maybe my colleagues are probably better than that, but I think that's really good. And one of the things we've noticed recently, relatively recently, is the trust have moved to safety cannulas away from the other thing. Have you noticed a change in success rate for that? Do you think the safety cannulas are better or worse, or no change?
It's funny because when we first moved over to them, I think we were all like, oh no, we don't like these, but actually they're brilliant. And if you tried to hand me an old style Venflon, I would be like, oh, I want a safety cannula.
They're a lot more tougher to get through the skin, we find, the older ones, where the safety ones obviously is better anyway. I know that obviously once you've put the cannula in, you shouldn't really come out to go back in. So I know there are certain people that do that. So obviously that's why it doesn't work for certain people. But obviously if you're not in the vessel and you come out, then obviously we would start again. We wouldn't necessarily go back in anyway. Obviously I know everybody has their own techniques, but so for us, the safety cannulas are great.
Well, that's good to hear, actually. And has there been a reduction in needle stick injuries since the introduction of safety?
I believe so. Yeah, I believe so.
Okay, excellent, good. Well, that's helpful because I know certainly there was a lot of chat about the way they feel slightly different with it.
Yeah.
Good. Okay. Good. Okay. And that's really interesting. Now, I think just moving away from the peripheral of venous access, and there's been a question about leaflets, because there's a sort of bewildering array of central venous access devices, aren't there? Is there a summary or a leaflet that we can get to give to the parents, and so we can go through them to explain to them? Or is that your job in CVAS?
So we like to see the families as well, if possible, because I think nothing beats like a little chat and show them the actual device. But on the internet, there are information leaflets available that you can give to the families, obviously along with being seen and spoken to. There's nothing more scary than giving someone an info sheet that has like loads of complications on there as well.
Okay, great. So we can find them on the internet, which is really helpful. And do you think, I'm just thinking, Andy, do you think EPIC has helped us with our decision making about putting central access in? I mean, for example, if someone prescribes a long course of intravenous antibiotics, would EPIC then flag that up to say, have you considered central access for this, or is that something you can put in there as a reminder or best practice reminder?
I haven't seen it. It probably would be, because I think a lot of people may not know what type of drugs they are and that they're basically or cause harm. I think part of the problem will be knowing how long that treatment is going to be. So that for the children needing chemotherapy, we know that's going to be a long term, and then that's, you know, sorted out because that's a given process. Whereas if it's a child that needs a couple of days of vancomycin, which is Lecicin, it's hard to know until the cultures come back what you're going to need. But a flag would be interesting to make sure that teams are aware.
Okay, I mean, with antibiotics stewardship, we should say how long it's going to go on for. So maybe that's something we could look at EPIC to see whether there's a, you know, another reminder about considering central venous access to try and save the peripheral venous access stuff going on. And is there any way people could come and spend some time with the central venous access service to try and see, especially people working on the areas where it's used a lot, about the different lines you're using and sort of complications for them to maybe improve the communication with the families?
We're always happy people to come and spend some time with us. The CF team and lots of teams, actually, the nursing CNS sometimes spends like a day with us, and then we go through devices and training. But yeah, so again, anyone's more than welcome.
Brilliant. Okay. Oh, that's really helpful. Thank you very much. Okay. Well, I think that's it. I've got through all the questions now, and it's now nearly 10 to 2. So I think we're going to wrap that up. I want to say thank you very much to the to Anne, Kerri-Ann, and Shelley for that. That was a really interesting run through a really important subject. This is recorded, so it will be available on the YouTube channel and it'll be available via Gold for people to look at before. And the information, you have to contact the teams if you want some more information for them. So that's great. So we'll put the slide. So if anybody wants to get a CPD certificate, please give us some feedback via the SurveyMonkey tool, which is going to come up in a minute. The link to that is going to come up hopefully in a minute. And you give a bit of feedback and then you can get a certificate if you want it. And remember, in 2 weeks' time, we're going to go to simulation. The team are going to show us their sort of vision of simulation in the future, which is very exciting. I've seen some of the stuff they're planning, virtual rooms and so on. And virtual reality is great. But that's it. So thank you very much, everybody. That's us for this week, and we'll see you in 2 weeks' time. Have a good week.